1, the draft UHMB annual plan. This report's been presented with some variants on the plan for next year and an overall summary. Please note this is a draft plan. I think the deadline is from memory 28th of April. So there will be further iterations coming to the board.
Yeah, that's right, Chair. Thank you. So the purpose of the report is to update the board on the draft plan for 22-23. It was submitted on the 17th of March as part of the Lancs and South Cumbria ICS plan for the coming year. And the board will be presented with the final plan at its meeting on the 27th of April. But the national submission, as Chair said, is due on the 28th of April. But the ICS require our plan by the 17th of April, so there's going to be limited times for the board to influence the final submission at the April meeting. The recommendation is that there'll be an extraordinary finance committee that's going to be scheduled on or around the 17th with delegated authority to approve that plan for submission. But just in summary for today, on page 179 of your pack, there's a table that just outlines some of the planning assumptions. So key ones I just want to bring to the board's attention are the increases in urgent emergency care demand, which is set at 6%. That's consistent across the ICS. And the 2% increase in referrals that's driving some of that waiting list shift that we mentioned earlier on in the agenda. There's a 5% set for COVID prevalence across the ICS, and for us there is an improvement to 5% for our sickness absence levels and a CIP delivery plan for 5% as well. On page 180 there is a table that summarises where our plan varies from some of the national guidance. So just key ones I want to bring to attention is the value weighted activity, which is a requirement of 4% more than what we did in 1920, and 10% more patients completing their elective treatment, which is known as clock stops. And that is due to some of the capacity constraints and the issues that I mentioned earlier. And that's a similar position across the ICS. Reducing the outpatient follow-ups by 25%, which is a requirement in the 2022-23 asks, won't be achieved because we have to work through a number of our backlog patients. So that's our IRD backlog that's in the pack of the IPR, and we've got to work through that before we can release that capacity. And that is in line with our PCB members as well. The increase in diagnostics ask to 120% of pre-pandemic levels won't be achieved because it's not necessary for us to require that level of capacity, because we don't have significant backlogs in our diagnostic PTLs to fill that capacity level. PTL is our patient waiting list. Just to note, in terms of our 52-week profile, we have a different 52-week trajectory compared to other PCB members, with an increase towards the end of the year. And a piece of work has been commissioned to assess whether that's down to modelling assumptions that's driven differently across the ICS members, or whether it's something else. So it's likely that that could move between the draft and the final submission across the ICS. Lastly, but not least, just the summary of the finance position. So page 183 through to 185 of the pack is the draft financial plan for 22-23. Just key assumptions, which, just to summarise the table on the last page, is the trust starts with an indicative financial deficit of 152.6 million versus a requirement to plan for a deficit of 28.4. An anticipated allocation of £94 million worth of system funding is then added into that mix, which is made up of the H2 full year effects. That's the H2 times 2 that Chris talks to. Ockenden requirements, COVID costs and elective recovery funds, and that then leaves us with a draft variance to plan of 30.2 million before any potential mitigations. In the table you'll notice a summary of potential solutions that have been identified that amount to 16.6 million, and that's a combination of some revised costing assumptions relating to COVID and ERF and the removal of some planned service developments. Even with those additional actions, there's still a gap of 13.6 million to achieve that control total at that stage. There is a requirement between now and the final submission date as part of the triangulation work between activity, workforce and finance as part of that final submission, and that's being led by the ICS.
Thank you. Clear, concise, good draft report. Steve?
Yeah, I just wanted to make sure colleagues had spotted one item that Leanne had mentioned on page 179. This current plan does not assume anything for safe staffing recommendations. Clearly that needs to be picked up in the next iteration.
Yeah, absolutely. Yeah, I think so. Any questions, colleagues? Jill, if I start with you, then David, and then yourself, Hugh. Jill? And then
Again, on page 179, on the planning assumptions, we're assuming 95% occupancy. And yet we know with 85% occupancy, we can do infection control and better quality care. And I wondered whether there was any chance we could try and do a bit more to get towards 85% occupancy, but is that too big an ask?
Well, Leanne.
So I think, thanks Chair, thanks Jill, good question. I think the 95% occupancy, we need to be cognizant that includes our Kendall and our designated day case type super green beds as we would use them. So that occupancy is as low as it's likely to get, and that has been the case all year. It's unlikely that that is going to shift significantly and improve. I think 85% would be aspirational. Across the ICS, that will put us out of kilter with our ICS colleagues. We are fairly low compared to our ICS colleagues because of the fact we have, the benefit of Kendall and some of our ring fence beds there. So I'd be hesitant about reducing that even further. We have taken into account the improvements around length of stay through the expected work around the not meeting criteria to reside that we mentioned at the beginning, the work around the frailty intervention team that Steve picked up earlier, and the work we're doing around Diagnostics. So I'd be hesitant about pushing that even further. Great question.
Thank you. Chris, do you want to come back to that, or is?
Yeah, I was just going to say, I mean, it is a statement of what the basis of the plan is. It doesn't mean it's the limit of our ambition, notwithstanding the points that Leanne has made. And remember, there's a load of still to be identified cost reducing measures that are required, and between now and the final version of the plan. And if there were opportunities, again recognizing Leanne's caveats, then we would look to do that to improve all areas of our planning.
Okay, David?
Yeah, it's just some of these things, I know there are planning assumptions being made, but I'm incredibly nervous about the assumption being made around staff absence levels in this ongoing COVID situation. Prior to COVID, our absence levels were above 5%, and COVID's added around about 2% on average on top of that through. So whilst we will do what we can to manage against it, we've also got to recognise that there's a requirement for the national terms and conditions to be changed around COVID in order to support management of that moving forward. So it will be difficult, and one we just got to keep under close observation.
Okay, thank you. Good point. Hugh, I'll go with Hugh, Adrian, then yourself, Sarah.
I've got a couple of points. The annual plan, obviously, I mean, some of the targets in this are incredibly challenging. I've never seen a target of, in all my time involved in senior leadership, of a 25% reduction in outpatients follow-ups, which is an incredible target that somebody has decided upon. And we have an indicative review date backlog of approaching 30,000 patients who are past their. So, and obviously you've said it, Leanne, that we're not going to be able to achieve that because of the number of patients who are past their review date. Was that based on the fact that we need to get all of those patients, all those 30,000 patients, back to an appropriate date before we can actually start? I'm not sure if it isn't either and or, obviously, because we can clearly start working on the whole, what needs to be probably a complete redesign how we manage outpatients, which I know is one of the A Health and Care Partners challenges. And so it's a suggestion that those probably go together rather than having to do one before we do the other. But there's a plea here that it seems to be a system-wide issue, this rather than just hospital. It's primary care as well, and how we completely redesign the way that we do follow up people after they've been seen in hospital, not just been seen in outpatients, but how we follow people up and how their ongoing care and how general practice particularly can get people back into the system rather than just through PIFU. So I'm just a plea that that's a system-wide and we engage general practice in that. But it is just to acknowledge that's an incredibly challenging target. The second point was the diagnostics. We're doing really well, aren't we, in terms of compared to most of the rest of the country in terms of access and waiting times for diagnostics. So I'm just wondering, are we still expected to still achieve 20% increase in our capacity? Because that means we may well have overcapacity in diagnostics. So that's yeah. And that my only other comment was about the draft financial plan. Is that again, combined with all the increase in performance targets we've got, that financial plan is again one of the most challenging I've seen for a long time. So I have to say I read this paper sort of feeling quite weak at the knees at the moment when I got to the end of it. But yes, those two, that's about that specific point as well, about the diagnostics.
Yeah, thanks, Sue. So really encourage system support in terms of the work we're doing around follow-ups and would welcome that support from primary care and work together on that. I think in terms of our focus, PIFU plus then demand management, and what we do notice in the annual plan is that our ability to clock stop, which is to complete that treatment, is higher than our activity. So we're more effective with the capacity we've got, i.e. we're managing some of that demand differently, which is obviously testament to some of the work we've already done with primary care. In terms of the diagnostics at 20%, you're correct, we'd have fallow lists, we'd have fallow endoscopy, fallow CT sat there if we operated at 20% capacity.
Or an extra 20%.
Yeah, an extra 20% over and above the submission that we're proposing. So to put it into context, we currently have about 6,000 patients on waiting diagnostics, and that's about the same as it was 2 years ago pre-COVID, so we're not deteriorating, and we are achieving the planning requirements that set a 95% standard for 2025. You've got to get to 95% by 2025 for diagnostic performance, and we're at that already and usually exceeding that. The capacity, I think, will come at a premium if we seek to put any more in. I think at Quality Committee, the question came, at Finance Committee, the question came around offering mutual aid to support colleagues out, which is obviously an opportunity for us to support colleagues across the PCB. Just to be mindful of the impact financially of that is obviously at a premium, so we just have to adjust for any finances within that. But for us, yeah, diagnostics is a strong position, but we're keeping pushing to 99%, so there's an internal stretch target.
Thank you. Adrian?
Just a couple of questions really about, well, the first one is about, I always find it amazing that there's only a 12-month plan when we get it so late. And I'm just thinking about you guys just being able to plan for how to address the backlog, you know, with the skills and capacity that you need. So first of all, is there a longer term multi-year plan around how we're going to address the backlog and what skills and capacity are going to be required? If so, particularly for People Committee, can we have a look at that? And can the Finance Committee have a look at it as well, just so that we can start to marry up how we're going to do that? So that was the first question to underpin this. The second thing is I totally agree with what Dave said about the sickness levels. I mean, they do look challenging, and also the vacancy rates that we're currently carrying and we anticipate carrying as well. I presume that other acute trusts are going to be in the scenario as well. So it's going to become an increasingly competitive market. So it's again about the mitigations and the measures around that. And also, just so that we're on the front foot with this, are we quite clear which are the business critical teams to address that backlog? You know, that we've got to get right.
Yeah, okay, I'll try and take each question in turn, Adrian. So, so the first one, in terms of the 22-23 plan, it does actually talk to more than just that single year. So it talks to requirements to clear backlogs up until 2020-25. So there is some long-term planning in that which our restoration and recovery plan focus on. In terms of that longer term plan around the clearing backlogs, I think what you're talking to is around fundamental demand and capacities in terms of each of those specialties. What do we need versus what do we have in terms of delivering that, you know, forevermore, so not just in the current year. So there's two pieces of work that we've got within the, and this is consistent across the ICS. The first is that KPMG are working with the ICS at the moment, and they've been working with national teams to develop a demand and capacity modelling tool that's just been released yesterday. So organisations across the ICS are signing up to that to complete that. So I'd obviously be recommending that we do part of that work with the ICS. We've also, with the support of Caroline and her team, we've got NHSEI working with us at the moment on some of our elective recovery. So they're reviewing our plans. They're also supporting us with some demand and capacity work for some of those more challenged areas that you've mentioned, which is key. In terms of our approach to just picking up the specific to the business critical ones, so I think there is business critical services that have a high level of cancer activity that we obviously need to focus on in terms of risk. But we also have a number of services such as general surgery and TNO that have got the longest waiting lists. Not necessarily the greatest risk patients, but the longest waiting lists, and therefore has a level of risk. And again, we'd be targeting at that first piece of demand and capacity in those areas that have got the highest risk, and then moving it down to the lower areas.
Thank you. Could I just ask a follow-up question just about how you're going to address the recruitment across the ICS? You're going to be in a competitive situation. Are you going to look at that with acute colleagues?
Yeah, so I think if Dave wants to come in terms of the work that he's doing with the HRDs across the PCB around recruitment, I think some of that's key, and we've got the opportunity to do that as we move into that PCB way of working now to support each other. In terms of how we've increased some of our capacity, we've used a lot of the independent sector, so not independent sector that I know drives our colleagues in primary care to distraction, but we've insourced some of our capacity, so using our systems, our processes, and we insource them, and that comes at a premium, but it's more consistent. You're not fishing in the same pool locally because they're coming from up and down the country. So that's proved successful for us, and particularly for some of the other organisations within our patch that have used that quite successfully. But if Dave wants to add anything further around the ICS recruitment approach, then I'd probably
David, I won't ask you to come in if you're right. I speak to Steve Fogg every week, so he's the chair of that area. So I know that they are beginning to look into that area of shared staffing, and I know the chief execs are having quite in-depth discussions around backing each trust up around vacancies and staff sickness and cover, etc. So I think more information will come from that from the next few months. But I'd just like to come back to your point, Adrian, about this is the annual plan. So we're putting through the draft that will hopefully get approval for April. The other issue you raised, which is what is our strategy for a 5-year financial plan, is slightly separate to this, and I'm just wondering if we can just dig a little bit deeper than that, and perhaps say, taking the fact that we know people are under a lot of pressure, but to the finance officer, Chris.
This afternoon, Chair, we're doing the 5-year financial improvement plan this afternoon.
There you go. Took the words out of my mouth. Thank you. Okay, thank you. I don't know how you did that, Chris, without your lips moving. Sarah.
Thanks. 2 questions. So one is my understanding of the figures. So it may be a too simple a question, but in previous years we've had an agreed deficit, as it were. So we've had a target and then we've had an agreed deficit, acknowledging that we have a different setup to other trusts. And I didn't quite understand whether that's included in these assumptions or if we're allowed to have that again. And then my second question was around the paper obviously says currently our planning varies from national planning guidance. So is the expectation that over the next few weeks we'll converge with national planning guidance, or are we actually aiming for a point where we acknowledge that we don't meet national planning guidance? And is that a risky position to be in? How does that fit with other systems?
I'll ask Chris to come in on the first point.
First point, so the the requirement is for systems to submit balance plans. It's not mandated that every organisation does, but every organisation has to submit a plan that is consistent with whatever the ICS is submitting. So how the ICS cuts the cake, as it were, can be determined. It's our very clear view that if a system balances, we should work hard to make sure organisations balance. There are enormous implications, cash flow implications of not doing that. I don't expect us necessarily to have a control total deficit as was agreed in the past, because we're in a different regime. But there are ongoing discussions and negotiations. There is a lot of process still to happen that will determine the bottom line financial position. The ones presented in the pack were a point in time, a statement of progress that had been made on the ICS planning round at the submission date. I think 17th of March, something like that. Now, the other component of this is that the ICS didn't submit a balanced plan. It's a £90 million deficit plan plus excess inflation costs. So there will be movement, there will be representation of these facts, but the regime is a bit different from that of previous years.
Okay, yeah, all right, that's a second
I'll
question.
take the other question. Thanks, Chair. So I think for us, as it stands at the moment, the deviations which relate to the 104 and the 110 activity levels in our diagnostics, that is consistent with the colleagues across the ICS. But sitting alongside the data submission is a narrative submission that explains the rationale for that and the reasons why we would never need to get up to 120% capacity, for example, for diagnostics. And we've included the rationale for that in our narrative. So we have revised the plan a number of iterations as we've gone through the ICS process. And so that's as it stands at the moment, we'll be shifting too significantly from that, with the exception of 52 weeks, which I've already mentioned. Internally, we'll obviously push continually to maximise what we do, particularly some of the work they're obviously picking up this afternoon around maximising our efficiencies, our productivity. There's likely to be change in guidance in relation to IPC requirements, which we're waiting for throughout this year, that may improve some of our efficiencies through things like theatres, etc., that will obviously then have a natural improvement.
So just to help you with your NED hat on, it's an iterative process. So the national planning guidelines come out, then the NHSI regionally put their view on it, and then for us, of course, it'll be the ICB now, and then it comes to the individual trust. And there are always variations on the dates. Sometimes in a good year, we might get allocations of funding arrangements in January, but realistically, it's always late. That's been the pattern in the last few years. It comes around this time, and there's been a couple of years in the last few years where it's come very late, where it's been beyond April, and we're still waiting for planning. I think the year before COVID was a bit like that. So there is room for each trust to come forward with their iterations and variances.
Thanks. It's so I think, Sarah, one part of your question was, is there going to be pressure to kind of converge back into where we've got that negative variance? Invariably, we haven't had formal feedback from the draft submission yet. I would expect absolutely on where we are saying for good reason we can't achieve certain targets or where the finances aren't in balance, that will form a natural check and challenge with the system regionally and nationally. I think under Chris and Leanne's leadership in particular, I'm very, very comfortable with the assumptions we're making and the stretch we're pushing and the way that we've built our plans. So if there is a check and challenge that forces us to kind of reconsider where we are, I'd be doing that really cognizant with the board about levels of risk mitigation, what it might mean for us before we submit with the delegated authority of the Finance Committee, which Leanne's asked for. We do meet regularly as a group of chief executives and the provider collaborative about taking a joint position, particularly on mutual aid or, following Chris's line on if we can all achieve the financials as a system, but we can't quite do it separately. What can we do to help each other kind of through that period? So it's a very narrow window now. It's 3 or 4 weeks, isn't it, before we have to submit this? But that dialogue will continue over the next couple of weeks, absolutely.
Okay, thank you.
Thank you. No more questions, then I'll go through the recommendations one by one. We approve the status that this is a draft plan. Yeah. We understand and agree and approve the variance away from the national planning. We, as Hugh has iterated, recognise the significant challenge and the risk to delivery, and that an extraordinary finance committee will be scheduled to approve the final plan submission to the ICS. It's a date to be confirmed, but you gave us a date. Did you give us a date for the
No,
finance?
I said it would be, the submission's got to be submitted on the 17th of April, so finance committee would need to convene before then.
Okay, fine. And then the final plan will be shared with the board of directors on the 27th, the day before the ICS submission date. Yeah, all happy with that? I think overall, in summary, you summed it up well. Huge challenges, massive financial pressures. It's going to be a really difficult year. Okay. Item 252, 5-year capital programme. Acting Chief Operating Officer again, advising the board on our 5-year capital plan. I looked at the financial figures. They seemed uncanny the way that you've made assumptions about spend, and they seem to have the finances that match them. But anyway, over to you.
Thank you, Chair. So the report is to advise the board on the updated 5-year capital plan for 22-23, following the draft capital expenditure limit that we've been allocated from the ICS, and the inclusion of the bids that we've been submitted nationally for national funds. So that's things like the Elective Recovery Fund and the CDCs, which is Community Diagnostic Centres. The proposal was agreed at Finance Committee on Monday, so that's the 28th, and is coming to board for approval. Just in summary, the board has a total of £138 million worth of capital funding over the 5-year period. 108 million of that is internal cash, with another 30 coming from things like new hospital programme and bids for CDCs. Just under 50% of that 5-year capital is focused on spend on clinical improvements to meet the requirements of our various service reviews, so things like CQC, urology, etc. And also includes the completion of major work programmes in 22-23. So that includes the stroke therapy space that we're constructing, the relocation of oncology, the work around ESTEC, and the upgrades to Medical Unit 1, to name but a few. There is significant focus, in addition to that, on reducing the risk resulting from our current backlog maintenance programmes, with approximately 16.5 million to be spent of that 5-year period addressing that risk. And the board can also see that there's £28 million approximately to be spent on the national priority areas of the elective recovery and the CDCs over the next 2 to 3 years. Just for clarity, the board is asked to approve the 22-23 capital programme of the 43.643 million, made up of the 20.653 internally generated funds and the 22.99 million external sources.
Thank you. Clear cut. Any questions from colleagues? David?
Yeah, hi Leanne. It may be just me, it may be because this is presenting the highest level plan, but I'm disappointed that there's no reference to upgrading and improving colleague facilities in the capital expenditure programme. It's something that's been identified numerous times, clearly come through on the cultural transformation programme, colleague rest areas, colleague changing areas, etc., etc. So whilst it might not have been a high level action, I would have hoped there'd have been at least a reference to it being picked up within those other programmes.
Okay, I'm going to suggest that that's left with the executives.
So I think Chris wants to come in on that point, but I can also update.
Okay, Chris first, then Chief Exec.
We've just revised our capital planning, governance and oversight arrangements, and included within that we've established a new prioritisation process. So most important to make sure, Dave, that you've got the input into that process, and it's all objectively set out. If the prioritisation process needs to be adapted, we can take that through management committee as well.
That's going to make 10 points. Okay, thank you. David, does that give you any reassurance? Okay, all right, thank you. Any other questions? Just a couple of points from me. On the 16C, the major refurbishment and new build, it talks about the community diagnostic hubs. It talks about the bid, including for GP networks, including the purchase of a mobile clinic room for hard to reach communities. I've no issues with that. The question I'm asking is, have we costed in the work that's being done around the Hollow 2 work? You know, the headsets, HoloLens, the headsets that our community staff are working, and would that be more proficient than a mobile clinic room?
Good question, Chair. I don't know the answer to that in terms of a response, but certainly can look into that for next week.
Just if we're doing research into that GP hard to reach communities anyway. Anyway, it's just a thought. And then the other one is just, Paul, for you as company secretary, and Nicola is taking the minutes, the recommendations on page 191, there are 2, but the recommendations at the frontispiece is 1. So I'm going to take all 3. Who's coming?
Jane.
Oh, Jane, sorry, I didn't see you there. Thank you. Jane?
Don't worry. I was just going to comment on the community diagnostic hubs. They are sort of very sort of, I guess, technical and things in the sense that they really are aimed at being able to access diagnostic tests rather than being able to see a person and examine them. So a lot of it is around the diagnostic testing in order that primary care or other people can make decisions rather than having to do a referral and then make those decisions. So HoloLens, I'm sure, will be useful in some areas, but it's probably more around being able to be equipped with ultrasound, endoscopy, etc., etc.
Thank you. Very clear. Thanks, Jane. So back to the recommendations, Paul. I'm going to take the 3, if that's all right. The recommendations on page 191 of the board papers, that the Board of Directors approve the report and the programme of works for the next year, 22-23. The second is, we note the allocations for future years and the ongoing development work of a future programme. Because that's part of the thing that you want to do this year anyway, and that will come, it's probably draft at this stage. You happy with that? And then the third one is to approve the programme based on the capital programme approval policy. Yeah, thank you. Just so that we've got it for minutes. Okay, great. Thank you. Thank you for that report. Very concise. We'll move on then to item 253. The mortuary security assurance. Again, this is a paper that speaks to itself, very clear, but I will ask the Acting Chief Operating Officer to bring anything to our attention.
Thank you, Chair. So just in summary, on the 12th of October last year, 2021, NHSEI wrote to trusts requesting that they review their mortuary security arrangements, and each trust was required to review their local operating procedures and the requirements set out by the HTA, which is the Human Tissue Authority. They have set standards and guidance that trusts are required to adhere to, and to take steps to assure their boards that they were compliant and advise of any further actions. That's why it's coming to today. So the paper provides assurance that with the exception of CCTV coverage, which I'll come on to in a little bit, the trust met the required standards. In relation to the CCTV requirements, which requires trusts to be effective CCTV coverage in mortuary areas that are reviewed on a regular basis by appropriately trained and authorised individuals. So the trust can be assured that all of the CCTV requirements are met that relate to the appropriately trained individuals having access to CCTV and having access to the appropriate training and counselling support. However, there are 3 areas that are not covered by CCTV in both of our mortuaries on the 2 acute sites. The first is the front door of the mortuary, the second is the family viewing area, and the third is the PM room, post-mortem room. So 2 of these areas, the viewing area and the post-mortem area, are not suitable to have CCTV, and there is an action in relation to the front door that isn't covered by CCTV that will be installed. CCTV order has been ordered this week, and the estimated time of installation is between 3 to 4 weeks from this point. So we'll be looking about the end of April for that action to be completed. And that's it. Thank you, Chair.
Very clear. The action points are 2 there. We're asked to note that we've submitted the response and you're taking the relevant actions around the locks and the CCTV. Any questions, Richard?
Just a couple of points. Can we make sure it either has been to or goes to the safeguarding committee?
Yeah.
I think that would be an appropriate pit stop if we haven't managed to do that. And I just wondered about the feasibility of smart card access just to act as a log of who's passing through those doors, given there are limitations to CCTV coverage.
Okay, yeah, take that as an action.
Okay, we leave you to explore those. Okay, thank you. Okay, colleagues, we'll move on then to item 254, Nursing Midwifery and Allied Health Professional Biannual Staffing Report, Executive Chief Nurse. Bridget?
Thank you. So just for the purposes, we have touched on this a little bit through the day. So just as a reminder, every organisation is required to use the Safer Nursing Care tool to evaluate as a minimum 6 monthly staffing requirements. And so in terms of what's been undertaken, so whilst there's been staffing papers coming through the organisation, we haven't used the Safer Nursing Care tool. So 140 staff were trained by the national team in February, just to give you some scale. And in January, should I say, and a census of the organisation and activity on the care we were delivering was undertaken for 20 days and completed, and the findings are presented here. In terms of the caveats, so there's some specific ways of how we measure care in specific areas. So what's excluded is accidents and emergency, because we are just validating the process for accidents and emergency. Similarly, community care tool has only been published last week. However, we're already working with the national team to complete that, so I think that's really important. But in terms of the findings, I think what was assuring in many ways is that so there's been a question mark in terms of staffing requirements for the organisation, that actually we'd taken steps very early on, even before my tenure here, in terms of actually using our rosters in a different way and not just a funded establishment. So what the findings have found, that actually there is a gap, certainly between healthcare support workers and registered nurses that are substantive. But however, the gap is smaller in terms of worked hours, because we've chosen to, based on professional judgment, actually provide those shifts anyway. So in terms of what the scale of that looks like, in terms of healthcare support workers, we're actually working at that value anyway, but the recommendation is to substantiate. And we will confirm in hard numbers what that may look like. It certainly looks up to about 50 healthcare support workers that there's an opportunity to consider substantiation. Similarly with registered nurses, and we already have a pipeline in, there is an opportunity to substantiate up to about 80 to 90 registered nurses. So there are some caveats with that for the board, and I think this is really important. So in terms of the next steps, I'll be working with the HR director and finance director regarding this. The census, in terms of practice, it's good practice to do it twice, so once in winter and once in summer. And as part of our programme of work, it will be undertaken in May and June again, and a board paper will come in July, and will continue to come in that cycle, and using the same technique. It's really important. I think that what's going to be different next time, it'll only be June or July, the correlation, we've talked about it through here, between the clinical strategy, what types of models of care we want to deliver, and how we do that in terms of both our workforce and how we spend our money, is going to become increasingly important for this organisation. So when you get the safe staffing reports in future, there will be a direct correlation between those, and that's purposeful, because I'm required as the nursing director to staff whatever it is care needs delivering, but we accept that we need to look at how we do that over time. And within that, I'm expecting to see alternative roles and different types of roles in how we deliver care. So I think that's important. And also in the June-July paper, community will come online, and also some decisions around emergency care. So that's just to set the context. This is an ongoing process. In terms of what we know now, in terms of it coming to board, it's not for recommendation, it's for information. So actually we're assured in terms that we actually have a process. It's part of the exit criteria, and that we're using the national standard, which has been signed off and validated by the national team. And that actually, in terms of the decisions that we now need to make, is some fine tuning of what the initial findings have found, and actually what we need to convert to substantiation based on what we know, with a follow up to come in June and July. Is
I think, what the findings are saying.
Sarah, and then Steve.
Thank you. Bridget, you've actually sort of answered one of the questions I was going to ask actually, which was around the community care group and when they come in. Can we just note that in the minutes, just because it doesn't say that in the report? So I'd be really grateful because I'm buddied with that care group. So just to understand when that comes through. The question I was just going to ask was at 215, I think, where we have the overview of the different wards and the care hours per patient day. Is there an intention to include, just trying to find the slide now on my screen, where we're saying what the current rate is, and there's a sort of RAV rating in there based on the number of care hours. What we don't really have is an indication of what good would look like in terms of how many care hours we'd expect for that particular ward. Is that something we expect to bring through at some point? Because that will help us understand where we are in that stuff.
Absolutely. So there's going to be a maturity opportunities through management of this. So in terms of model hospital and the relationship between care per patient per day, absolutely needs to be in there. And you'll also see some referencing through either our reporting through IPR, but certainly our finessing of roster management will help certainly the reporting of care per patient per day. So yeah, absolutely.
Great, thank you. And just as a follow-up, if we could have a glossary of what specialties are in which wards, because that will just help us understand the background of why care hour per patient day is higher for some than others, if that makes sense. That'd be great, thank you.
Thank you. Steve?
I just want to recognise how important this report is from an assurance point of view for the whole board. Really welcome it. And I think it points up. I also want to link back to the comment that the Governor made at the end of the meeting in terms of the inherent value of substantive post holders rather than temporary post holders. But really to point up the challenge for us in building from this into demonstrating a better deployment of those substantive resources using the new models of care that you mentioned and that Jane mentioned earlier. That's our route, as I see it, to charting a path for better use of resources, to use the phrase. If we really understand the model of care, got the right level of staffing, and we have a chance of being more productive. Thank you.
Really good points. I think we've discussed a lot this morning around staffing issues and that circle that a lot of places find themselves where, because we need a recruitment strategy that fills these posts fairly rapidly, that has an impact on agency and bank, which then has an impact on the finances, which then impacts on the operational planning cycle. And so we have got ourselves in that cycle. But I agree with Steve, this is a really welcome report. I know that the second recommendation is the board is asked to take assurance that we've got national standards to assess nurse staffing are in place and we've got reporting schedule. So I do support what you've said, Steve. Some really good points there. You?
Yeah, I think this is really helpful. What the question it immediately raised for me was that over the past year we've been sort of hearing that our nurse vacancy levels are really very low, and we've been sort of patting ourselves on the back because they're so low. But this now then raises the question of actually they probably aren't, well, they aren't that low if when you've gone through that work and identified what proportion of the temporary staff should become substantive. On the basis of the tool as I read it, actually it's slightly beyond what our temporary, the amount we need is slightly beyond the temporary that we have. So we're spending 10 to 11 million pounds a year on temporary staff based on H1 this last year. What proportion of that, I'm not asking for exact proportion, but just a sort of a guide, do you think over this next year we would be converting to substantive posts? And with the stuff we've got in the pipeline, which you've talked about with the international recruitment and nurse apprentices and so on, how much of a challenge will that be to get to that? Because we do know, certainly from looking at incidents and various other things, that where wards end up with quite a large number of temporary staff on a short-term basis, it really affects the quality and such like. So obviously the speed that we can move to converting those temporary to substantive is really quite important for us. So it's quite a complicated question that, but it's just that feel I had just reading this.
With your permission, Hugh, I'll summarise your question then in a single question. When will we get these vacancies filled?
Okay.
Well, it's not just when, it's just what proportion we think we will aim to get this next year. Yeah.
Okay, so there's a couple of things for me. So in terms of when I think, this is my view from experience, that our ask will change over time. So in terms of the healthcare support workers, will be required and work with Dave. We've had good, we're able to do that well. The registrants is a different conversation. So we're in a pipeline of 150 and what we can do. And I was expecting that question is then bring back the plan next month of how we're going to achieve it. However, my caveat of this is we think about our models of care, and you've touched upon community quite rightly. So we've done some work on the inpatient beds, but in our models of care and what we're trying to deliver, so the conversations we've had all the way through is around not always patients being placed in the best place for them. So that's certainly a challenge for us. Yet we're having to staff, and absolutely rightly, safely. But I think our challenge will be not when we will meet that target, but are we providing care in the right place? And if not, how do we start to look at the services we're providing to do it differently? And I think that the ask for us will be, so in terms of that conversion from temporary to substantive, it's about, it could be up to about, looking at the numbers, about say 50% of what we're spending. However, I'm waiting for, we've got the national team in our community looking at the community aspects now, and I think that's the broader discussion we need to be having, because we still have where people are staying and residing somewhere they may not be best placed. Harm will happen, and hospitals aren't always the best place, and I think that's the bit that this will move over time. We've got the juncture in July and January, and I think that's how it's not. I'm not trying to. That's what I genuinely feel.
No, I think that was the point I was trying to make about what proportion will move, because if you move suddenly to all of them, you just hardwire a permanent establishment, and then you realise this isn't actually quite how we want it. So it's sort of that was the sense that we would be moving not to 100%, but what proportion. I think I'm really reassured by that. Thank you.
David, and then Chris, last comments on this item.
I think it's a really valid question to ask. I don't think we can give a valid response to that question today. The recruitment market has changed massively over the last 2 years, and the healthcare support worker market in particular, one which we've never had difficulty in recruiting previously, is extremely challenging now because of post-COVID intentions, other competitors in the market, etc., etc. I think the piece of work that Bridget and I need to do is to really build that plan, set some clear trajectories and monitoring, so we can come back and hopefully answer that question at the next board meeting. But I can't give you any assurances today on what we're going to deliver by when. We need to build that plan, and we need to have a plan to monitor it with some clear trajectories. And we also need to understand this isn't just about workforce, isn't just about nursing. We also need to look at the efficiency elements of it as well, because I think the other aspect that the Bridget's report highlights is how we use e-roster to really drive full efficiency of the workforce that we've got.
That's something probably the People's Committee will look at in more detail. Okay, Chris.
Thanks, Chairman. The couple of things, Bridget's already alluded to the fact there's more work for us to do to just validate components of this. I mean, one of the things that we've agreed on and we're working hard to ensure is that both sides of the equation are done equally well in the implementation of this, and you don't have large stranded costs. The phasing of what we don't spend versus the new spend, it will be tricky, which is why we have to continue to work through that. But I'm satisfied that we'll have much better control environment arrangements in place for that. Interestingly, that the overall, we think that you know, we expect this to be manageable within existing run rates. The challenge for us, therefore, becomes the fact that we are reliant for our financial improvement trajectories on reducing high cost agency or bank. Most of this has been bank, so we're just making sure that it all triangulates with what we're saying about the efficiency program, and we'll make sure that that's correct. What I would say is that this gives us a chance to be clear that variations are not rate or cost related. They would be much more around process, and of course the implementation of these proposals gives us a better chance of improving process.
Thank you. Okay, thank you for the paper. We're asked to review the content of the safe staffing paper, which we've done, and the processes used to collect and present the data. I think we've done that, colleague. And then take assurance, very important, take assurance that national standards to assess safe nursing staffing are in place, and reporting schedule to inform the trust board will be used going forward. Yeah. Thank you. Bridget, thank you. Item 255, colleagues, brief one, new hospital programme update.
It is exciting one, this is, Chair. So this is the short list of options now that have been through the due process across kind of the new hospitals programme project, following months worth of, has Rebecca just joined us?
Yes, I'm here, Aaron.
I'm doing this one though, Rebecca, am I just checking? Yeah. Good. So that's just gone through its process of some 12,000 different colleagues and community members kind of commenting on the long list of options that we presented to the board previously, using the case for change criteria to go through a process with the strategic commissioning committee at the Lancashire South Cumbria ICS level, who have the overall responsibility to kind of approve these options, which they've done. So we've now got to 4 shortlisted options. Now, for me, that just gets us into a completely different space with our clinical and operational teams to start to talk a bit more candidly about what's in them, how do they look, what are the facilities, how do the design start to work, how does that case for change programme get met. And just to be clear that the 4 shortlisted options, so we can minute them at board, a new Royal Lancaster Infirmary on a new site with a partial rebuild or refurbishment of the Royal Preston Hospital, a new Royal Preston Hospital on a new site with a partial rebuild or refurbishment of the Royal Lancaster Infirmary, investment at both the Royal Lancaster Infirmary and the Royal Preston Hospital, allowing partial rebuilding work on both sites, 2 new hospitals to replace Lancaster Infirmary and Royal Preston Hospital on 2 new sites. So obviously this still includes investment in our Furness General Hospital site, which was also included in the call, to ensure that it is right size, 21st century infrastructure, etc. But very clearly in the call for new hospitals investment, the RLI and RPH have been identified as the worst condition of the state and the highest levels of risk, and that's absolutely right and proper. The next steps then from this shortlist is to go through further analysis on affordability, design, the case for change criteria being delved into a little more detail, with a decision to be made over the next 6 to 12 months on consultation. So depending which of these options start to become the preferred option will dictate whether there are substantial variation and need consultation. So there's 2 programmes of work now that the central team will be supporting organisations to complete, which is a pre-consultation business case in anticipation that consultation may be required, but also a strategic outline case, business case under the Treasury guidance, so we can pull those 2 together in tandem. And the expectation is that we are still on track to have the business case approved 2025 and the build of the new facilities completed by 2030. So we're still on that trajectory in terms of the development of the case. I've been at 2 colleague summits in the last 7 to 10 days. I think there were about 150 to 200 colleagues on the first one, about 30 or 40 last night, Rebecca. It's much harder to get people to a 6:30 to our fate meeting, I noticed, than it was to get one Tuesday afternoon last week. But when we went through that with the colleague summit, I just made the point that having just said that the new build should be in place by 2030, I know some people can kind of switch off, 2030 miles away. we are as far away from 2015-16 today as we are to get to 2030. And 2015-16 really doesn't feel like that long ago to me at all. I can still remember the annual plans we were producing and kind of the meetings we were having here. So really exciting. First, gateway in terms of the endorsement of the shortlist, gets the teams into a different space. We've got all of the work to do in front of us now on getting these cases to a position where no one can say no. And that's the ambition. So it's here for noting the approach we've taken as a system to get to this shortlist of options. Note that they've been endorsed by the Strategic Commissioning Committee and for the board to endorse the shortlist, Chair.
Yeah. And the same paper is going to
Lancashire Teaching.
Yeah, Lancashire Teaching. Yeah. Okay, so it's fairly clear. Rebecca, thank you for joining us. Just in case there are any questions or the Chief Exec doesn't present, you have done. So we know the approach taken to produce. Can I just check first of all, there's no questions or queries? Jeff?
I just want to say something a lot of you have heard me say before, but I think it's really important, and that is medical practice can be much better by the correct design. And so I don't want to put pressure on anyone, particularly like Jane or Bridget or anyone. It's everyone's job really, this, but the more people, the more clinicians of all sorts in Morecambe Bay and out, trust and out with the trust that can become involved in this process will inform. I'm no architect. I've seen great designs that improve clinical efficiency, and I've seen terrible designs. I've worked in half a dozen hospitals that have been awful in my lifetime. So if we can mobilise all the clinicians, if all of us can take that responsibility to try and spread the message and to help inform the process, I think it'd be really helpful.
Thank you. We'll take that on board. Thank you, Jeff. I'm sure Rebecca will feed that back into her team. Any other points? No, thank you. Then we're asked to note the approach taken to produce a short list of options in line with key guidance and the next steps. Yes, and endorse the short list of options. Thank you. Thank you, Rebecca. That means our board of directors have complied with putting it through our board in line with the suggestions from the main committee. So we'll move on then to governance and assurance. We've got an item 256, standing financial instructions, scheme of delegation. Paul?
Thanks, Mike. Just a couple of points really, just in addition to the information that's contained in the report. This has been through the Finance Committee on Monday, and the recommendation was to commend the revised scheme of delegation and standing financial instructions to the Trust. Just want to make the connection for board between this approval and some milestones within our recovery support programme within the SFIP. The approval and deployment of new SFIs and the scheme of delegation was a milestone due by the 1st of April. So if the board are minded to accept the recommendation from the Finance Committee, we will have met that milestone. In terms of deployment, work is now underway with another element within the SFIP programme. So moving away now from the financial control environment to the financial skills module. SFIP and the new SFI requirements will all form parts of that, and there'll be deployment there to make sure that people are aware of the new roles and responsibilities that they have. With that, Mike, I'll commend the approval of those documents to the board. Thank you.
Thank you. Note we've sent through finance sub. Yeah, we approve. Great. Thank you. Move on to item 257. Lorraine, Head Governor update. We've got your written report.
Yeah, in addition to the written report, we now have a new senior independent director in Jill Stannard, and we welcome her experience and expertise. Subgroup committees will recommence in April due mainly to the pandemic. These have been missed, but will now be another inroad to Governor input in helping the Trust move forward. The staff survey results are out tomorrow, or at the end of this month, which is tomorrow, and our governors will be informed of its outcome. At our last face-to-face informal meeting of governors, we all felt that we should have a defined path of being and showing what good governors can do to enhance good rapport all round. So we are going to adopt the C's programme. as the trust have the 3 A's, we've got the C's, but there's not just going to be 3. The first 3 that we're going to look at is cohesion, which we need to be a cohesive group of people with all our mixed abilities to help the trust to strive forward. The second one is communication, where we need to communicate with one another to enable us to use our skills in making the council a strong and visible group of people using the correct channels and remits of our role to get more suitable results. And the third one that we're looking at is constructive friendly criticism, where we are actually to be supportive, not obstructive, to enable progress from what is and has been a very difficult time. So we hope to progress from there in future meetings.
Great. Thank you, Lorraine. Steve?
Just a suggestion, Chair, really. I think this report would sit better if it was moved up the agenda alongside yours and the Chief Executive's report, rather than being at the end of the meeting.
Yeah, happy with that. Yeah. Paul, did you get that as a recommendation?
Yeah, I got that, Mike.
Lorraine, you happy with that?
Go on then.
Lorraine, it does mean that me, you and the chair now will have to coordinate so we don't cover off each other's reports, which is a habit of Mike and mine.
Regulation.
Yeah, great, thank you. We know your report, colleagues.
Yeah.
Thank you, Lorraine. Okay, the items 258, 259, 260. There's no urgent business to bring to my attention. Paul, anything there?
No.
And we've got the attendance monitoring schedule of business. I'll just check with colleagues. Do you feel we've covered the agenda sufficiently? You walk out of the room with a sense of assurance in key areas? Yeah. Okay, I'll close the meeting then at 12:13. Thank you. That's the closure of the public board. We will reconvene as a private board at 12:30.